Okay, thank you, Giovanni. Well, first of all, I'd like, good morning, everyone, to thank, the surgery organization for allowing me to share with you, the last talk, the most challenging, I would say, just to introduce a new way of having a look to this huge problem, this the surgical therapy of bariatric problem, of obesity. I think, all of the other options are really available, but let me talk a little bit about the duodenal switch. Okay, I think this experience in Europe are going to be, this is my disclosure. My disclosure going to be here. You can see how we perform in our department of surgery there in Madrid, in Spain. We are doing a sleeve, 44% of our patients, and the same number of patients regarding, the SADIS procedure. The one anastomosis duodenal switch is a modification, a standard procedure, as a Roux-en-Y duodenal switch, a Roux-en-Y gastric bypass. We are doing 12 to 13% of cases are revisional. And now, metabolic surgery, all of it's a very old history, coming back from, the last century at the beginning. And then here you can see how, many authors. And finally, in 1979, Nicolas Copinaro in Italy, they described the one-loop BPD, not Roux-en-Y, one-loop BPD, many, many years ago. And then in 1998, he described, the classic bilioprognathous diversion has been the Roux-en-Y bilioprognathous diversion, a very important point to take into account. So let me go through that some historical landmarks, some European countries' experience regarding this technique, and finally, also I usually call the Iberian experience, Spanish and Portugal experience, our clinical trial. I'll show you later on. Here you can see this historical landmark. As I mentioned before, in 1979, Nicolas Copinaro also, described the standard BPD, and then, after being aware that, those untractable duodenal ulcer, Tom de Mister, invented the concept of diverted duodenum for healing or for treating the duodenal ulcer. Then, Douglas Hess here in the States, combined both concepts. He combined, the concept of the bilioprognathous diversion for Nicolas Copinaro and the duodenal exclusion, duodenal diversion for Tom de Mister, and they create the duodenal switch. It's going to be the concept of this operation at the end, the middle of 90s, there here in the States. Here you can see, the paper published for Douglas Hess in this scenario. I cannot have the pointer. How can use the pointer because it's not? Oh, now, okay. The mouse, but it's not working probably. I don't know. Anyway, okay, I'm going to do it slowly. Now here you can see the nice result that Professor Hurst pointing out, having a weight loss, a long-term, very nice result, even having excellent or good result regarding, the condition regarding the poor and very bad result in very, very few cases. And here you can see, even regarding the most important comorbidity, that be type 2 diabetes, how this procedure, the standard Roux-en-Y duodenal switch, can long-term, I try to pointing out, to underline the long-term result of this procedure in this scenario here in the US. And regarding with a very low morbid mortality, less than 1%. We have to take into account this experience was in open surgery. Before the introduction of laparoscopic surgery. It was a tough way to introduce laparoscopic surgery, trust me, because I did in my country many years ago. And another important issue is now even the Roux-en-Y gastric bypass is going to be the gold standard. Many patients, especially the very overweight patient, regain weight as the time goes by. It's going to be one of the most important problems is the number of Roux-en-Y is a pool of different experiences all over the world. What about Europe? In Europe, especially, the Scandinavian team, they published the prospective clinical trial because there in the north of Europe, people are very heavy. BMI over 50, like here in the States, they have very heavy patients. A lot of patients with BMI heavier than 50 and very metabolic patients. In this randomized trial in patients with BMI between 50 and 60. They compare duodenal switch and gastric bypass. We have to be aware that the duodenal switch is going to be 100 common channel and 150 of the alimentary tract, and the Roux-en-Y was 50 biliary limb, very short biliary limb of those days, and the standard 150 of alimentary tract in this operation. But the results 5 years in this perspective are very clear, in favor of Roux-en-Y duodenal switch. Very clear regarding the BMI, very clear also, in the difference of weight loss, the two procedure, the Roux-en-Y versus the standard duodenal switch. And also regarding the control of the most important comorbidity, type 2 diabetes, was much better with the duodenal switch compared with the Roux-en-Y gastric bypass, and also the lipid control, the lipid profile, our cardiovascular risk, not only type 2 diabetes, hypertension, and lipid profile of the patient, much better regarding the duodenal switch compared in this randomized clinical trial compared duodenal switch with Roux-en-Y gastric bypass. And regarding the adverse effect, that is clear in this trial, it's going to be important regarding some patients with duodenal switch who had some more effect adverse. So the conclusion of this trial is going to be that the duodenal switch got better or greater weight loss and greater improvement of the different comorbidities, but was associated with the most surgical, nutritional, and gastrointestinal adverse effect, with the most very important conclusion. And the complication that should one expect of the standard Roux-en-Y duodenal switch at the standard BPDDS, and marrow stools, untreatable GERD, dilation, micronutrient, and some other deficiencies. This is the reason that we think that the duodenal switch was the long-term data, was the champion. Many experience. Here you can see Barbel, Antoine in France, Marceau in Canada, Topard in France, and Hess is here, as you're saying. So why, not going to be even more popular, math show us here in the States, only 1% of those procedures are going to be performing in this way. Probably become more complex, especially in the era of laparoscopic surgery, comparing with the open surgery. Don't forget that. And then, become malabsorption, hyperabsorption going to be a too big problem. This is the reason we thought in 2007, switch to the switch. It's going to need to compare a standard classical Roux-en-Y to one anastomosis duodenal switch Osadis procedure, because we consider having a good revising, all the Mr. experience, there is no need of Roux-en-Y diversion. Why? We didn't get any answer when we asked ourselves about why to add a Roux-en-Y in a duodenal switch. So this is the reason, because we start doing, in our country here, you can see Aniceto Baltasar from Alcoy from Spain, with the fathers of the duodenal switch club here in the state, Picard Marceau and Douglas Hess. They introduced the duodenal switch in Spain in an open era. This guy, and we followed this, and in 2007 we were coming back, transforming our open approach duodenal switch to a Roux-en-Y duodenal switch. It was terrible. This is the reason we thought, why to do another anastomosis? Why to close the mesenteric defect? It's not important. We started in 2007 our modification of the BPDDS. It's the one anastomosis gastric bypass. This is a cartoon by our friend Caetano Marchesini from Brazil, showing the principal data of this procedure. Is to perform a sleeve, not very restrictive sleeve, over a bougie of 18 millimeters, and perform one anastomosis to the ileum. We started anastomosis 200 from the ileocecal valve, and then we changed in 2009, 2 years after completing our first 50 patients, to perform the anastomosis 250. This is the clip, showing how even using a 18 millimeter bougie, going closer to the bougie, we can do a very nice receive. We use reinforcement in this part of the operation, and then we perform a very far away dissection of the duodenum, a very, democratic dissection, different from the standard duodenal switcher. We don't use reinforcement in that, and then we perform a tension-free duodenal duodeno-ileal anastomosis you can see here in this cartoon. And then this is summarizing our experience. We operated, as I mentioned, our first 50 patients, 200 from the ileocecal valve. Then we changed to 150, and then we are doing in a lower BMI patient and also metabolic anastomosis, 300 from the ileocecal valve, as many other teams here at the States. We are operating more than 700 patients now. And I present, SMBS. Some years ago, I found this picture in 2016, showing our 5-year results in this poster here in New Orleans. And then, we're now accepted our 10 years publication, long-term publication, published in Obesity Surgery a couple of weeks ago. In this paper, we summarize our 10 years experience with the very important cases. The pointer is not working very well, but anyway, here you can see that our patients are very, very heavy and very metabolic. BMI, medium BMI 45, 42 patients under insulin, 91 hypertensive, 81 sleep apnea, and 118 with dyslipidemia. And here you can see our follow-up is going to be very important. Again, 10 years with a follow-up of 75%. 5 years, we had a follow-up of 84%. And regarding the weight loss, we had, 5 years weight loss, total weight loss 38, and with a percentage of failure 5.7, and 10 years total weight loss 32, with a percentage of failure of 11.6. Here you can see the standard Roux-en-Y duodenal switch published by Hess and Hess in 1998, and here overimposed is our SADIS procedure result, mimicking both. But not only, the way, but the way of we controlling the comorbidities. Type 2 diabetes, in our 10 years experience, we're going to be here 10 years with no treatment, 61% of our patients, with anti-diabetic oral therapy 27, with insulin 11.5 of all our diabetic patients under insulin. But also the way that, maintaining the antropyloric area preserve the functionality of controlling the glucose, the variability of the glucose level. Here you can see in a study we published in Obesity Surgery about 12 patients 5 years after complete remission of their diabetes, how we monitoring, for a week the glucose level, and in those patients with Roux-en-Y, the percentage of patients with blood glucose level less than 70, it means hypoglycemic, worse in the Roux-en-Y. The percentage of patient glucose level in a normal range, 70 to 140, better in the SADIS procedure, and hyperglycemic glucose level higher than 140, worse in the Roux-en-Y gastric patient. We already performed this Iberian experience comparing the standard Roux-en-Y duodenal switch versus SADIS procedure in this Iberican study, 2 hospitals from Spain, 1 from Portugal. And here you can see, the design of the study. We couldn't convince our colleagues that performed the anastomosis 250 from the ileocecal valve. So we performed all the anastomosis 300 from the ileocecal valve. Here you can see recently sent to publication. Our 5-year result is this controlled randomized clinical trial showing the comparison between duodenal switch and SADIS performed 300 from the ileocecal valve. Here you can see 5 years, the duodenal switch, the standard duodenal switch, is going to be more powerful regarding the total weight loss, the BMI changes. But regarding the control of the most important comorbidities, type 2 diabetes and dyslipidemia profile, are going to be very, very similar between the 2 approaches. Again, regarding the total weight loss, more powerful, the standard Roux-en-Y duodenal switch, but have to be aware that the anastomosis was performed 300 on the ileocecal valve. We thought in those patients very heavy, BMI over than 50, and very metabolic, 250 will be ideal. What about, as I mentioned, our colleagues from Middle East say that sleep is going to be it's an epidemic procedure, but sometimes it can fail. What to do if we fail a sleeve gastrectomy? It's an important dilemma, not only in the Middle East, but also in all over the world. And here in the States, we have 52% of all the procedure performed inside the procedure. We have very options: banding, sleeve, plicating, Roux-en-Y, one anastomosis gastric bypass, BPDDS, SADIS, SAGIS, bipartition, SASI, and probably there are so many other approaches. It's a debate. In our humble opinion, I think, we published our 5-year result in this approach recently in SOAR, comparing, analyzing the result of the studies after failed sleep. And our result going to be here. You can see how the patient did very well, after the sleep, and then they were bad as the time goes by, and then they were submitted to studies. And 5-year result, very nice result regarding BMI, regarding total weight loss, and regarding weight loss. And what patient went better? Those patients with initial BMI less than 50 submitted to studies after failed sleep. Those patients that had to be operating 3 years after failed sleep, and those patients that responded much better to the sleeve gastrectomy as the first operation. And when we compare to perform one 5-year studies, but 2-step 5-year going to be almost the same. At the beginning, we thought that the first 2 years, one-shot surgery would be much better, but at the end of the day, 5 years later, going to be the same result. Let me share with you this important paper, in my humble opinion. It's coming from a multi-institutional study from Holland, and it's going to be comparing after failed sleeve compared to Roux-en-Y and SADIS procedure. In this paper, SADIS was performed 250 from the ileocecal valve. And then here you can see the result. 6.9% total weight loss regarding the patient, 26% the patient submitted to SADIS after failed sleeve, and 6.9% the patient submitted to Roux-en-Y. If you have a look, very close look, the result of the Roux-en-Y after failed sleeve is similar, go to the left of the image, that the same result that after sleeve. So it means that performing Roux-en-Y after failed sleeve for weight regain is not the solution. Regarding nutritional deficiency in this study, compared Roux-en-Y with SADIS, there is no difference regarding SADIS and Roux-en-Y, even though, the vitamin B12 were worse in the Roux-en-Y, are going to be as expected. In this paper, have a very nice result. Here you can see the thing going to be better. This is the summary from the proper journal, showing that this is the methodology of the study. Regarding how there was 140 patients, 68 to SADIS, the other to Roux-en-Y. But the conclusion you can see in the right side of the slide: conversion of sleeve to SADIS leads to significant more total weight loss compared to Roux-en-Y surgery, with no difference in quality of life, complication rates, or macronutrient deficiency. Only when GER was the problem of converting a sleeve to Roux-en-Y was the ideal strategy. So it's going to be, those results came up with the endorsement for the IFSO Federation regarding recommending, recently updated here as SADIS as offer a very important operation regarding what to offer in some patients as a very metabolic and bariatric procedure, and provides an improvement in metabolic both in maintaining over the medium term. Probably our paper 10 years going to be add some more information regarding that. And also here in the state where in 2016, Mao, can remember this journal with SADIS was considered investigational, 2016. Now, in 2022, going to be endorsed also for the American Society of Metabolic and Bariatric Surgery as, a modification of a classic Roux-en-Y duodenal switch, as is therefore endorsed by SMBS as an appropriate metabolic bariatric surgical procedure. It was the status of the procedure all over the world in 2016. Some centers were adding to the experience, and now in 2020 we have some more all over the world in all the continents. So, for summarizing, as the passed away Dr. Scapinaro said, high-passivity procedures are like a sport car, and while it can perform extremely well when poorly managed, they are destined for an accident. So, I think, it's our main strategy now is to use this procedure in very heavy patient over 50, BMI of 50, and very metabolic patient. But if the sleep fail, is our ideal procedure, except if the patient is very old, patient with with very bad perform sleep, or patient with GERD, depending on the age, follow-up, and so on. And here you can see is a study we performed with some US surgeons here in the state, showing that it's true that the total BPDS was almost 63% of all the procedures. I mean, 1%, as might show us. But also, yes, I'm finished. Yeah, absolutely. No, I'm finishing. Just to show you that the increase of revisional duodenal switch is going to be 140. Including the SADIC procedure in the last year. I think. Schopenhauer said that all the truth pass through 3 stages, and 30 accepted as being self-evident. This is the standard duodenal switch, is mimicking the First World War. And then the duodenal switch, can be, the SADIC can be approaching the people performing Roux-en-Y, and standard duodenal switch to perform one anastomosis duodenal switch. And the SUSEC at the end of the day is going to be the SADIC procedure, a multidisciplinary approach. Thank you very much for your kind attention.